Hey guys, welcome back. Broadcasting from the secret Mad Medic's lair here again today. Today we're going to talk about actually one of my more favorite topics to discuss, and that would be chest trauma. And if I can get the right slide up here, there we go. Chest trauma. Yeah, we love chest trauma. It's kind of a meat and potatoes thing for a paramedic, and more indefinitely. So there's a lot of things that we're going to be going over. There's a lot of structures that are vital to our survival in the thorax. And because of that, we need to know about the things that can happen that are bad, especially involving trauma. Okay, we know that the heart's in there, we know that the lungs are in there, but look at all the other structures of the tracheobronchial tree. The esophagus. We lose track of those things as well. By the way, 25% of all motor vehicle deaths due to thoracic trauma. Okay. So you need to be thinking that, especially, and you got to remember, you got that steering wheel there. Basically, one word, gigantic battering ram for if you're going forward and get hit and you're squashing that thing. It's just crushing the chest. Okay, so there has been an increase in penetrating trauma due to violent crime. So again, these are things that we need to start considering when we're dealing with the thoracic trauma. Again, the good news is that our thoracic cavity is well protected by the rib cage. Again, and this is the basic, the fundamentals of the rib cage, of course, and that we learned that back in A and P. But remember that we've also got a lot of lines through there that we're going to use to describe the mid-axillary line, the mid-clavicular line. All of these are going to serve as landmarks for identifying where the wounds are. Okay. And again, the thoracic outlet is the superior thorax opening. That's this part up here. Your diaphragm is what separates thoracic and abdominal trauma. Okay, and again, it's a dome-like. It is again, when it relaxes, it goes up. When you contract it, it goes down. And again, that's having to do with our breathing. So remember, if we get a tear in that thing, again, causes major problems. Now, remember that we've got all kinds of musculature around that, again, that can cause problems, that can cause pain, especially when injured, okay? Remember that your tracheobronchial tree is not infallible to damage, so you can actually have a right or a main stem bronchus actually break or tear as part of trauma, okay? And again, usually with catastrophic effects, by the way. So the central space in the thoracic cavity, it's got all these lovely things in it that are all pretty much is required for us to be living. Okay, so pretty much all of these things, if they get damaged, again, going to cause some problems here. This would be like a CT scan cross section of what you were actually looking at, of the different structures in the chest cavity. Again, your heart, we all know about this guy. We already talked about that. Let's talk about pericardium, epicardium. But the pericardium, by the way, is the membranous lining that surrounds the heart. So what happens when we get a little bleeding in between that and the actual muscle? Okay, this is this is where you get your pericardial tamponade. It starts to limit the space, and none of these, by the way, they're slightly flexible, but at a certain point, they're not going to be able to move. And they're not going to be able to expand, and then that's going to cause us some problems. All right, now we talked about the great vessels already. Your esophagus, again, and remember that still goes through the thoracic cavity, so again, it can also be a source for pain. All right, your blunt trauma, again, this is the kinetic energy is transmitted. Blast injuries also cause that. But it can also cause the damage in the hollow organs, and since the lung is pretty much a fairly hollow organ, again, lots of damage can happen because of that, because of the pressure waves that come from that. Your crush injuries, remember, not only your soft tissue, but you start breaking bones in there, and that prolonged crushed injury, by the way, starts degrading the muscle fibers, which sends the patient into rhabdomyolysis. Long and short is protein in the kidneys that cause them to stop working. Deceleration injuries, again, it's when you go forward or your rapid forward motion back into a quick stop. And again, they can rupture the myocardium, the great vessels, known as kind of the paper bag syndrome. By the way, the alveolar and the tracheobronchial, they can actually rupture, causing a pneumothorax. Okay. Again, penetrating trauma. This again, figure out what it is that caused it. Low injury, high injury. This would be a good example of a low velocity wound, but again, still extremely serious. Again, because of all the structures that are going through there. All right. So remember, your high energy rounds is from your military, your hunting rifles or handguns, and they could cause extensive damage, especially if they go to bouncing around in the chest. All right. So signs and symptoms of a chest wall injury: decap, BTLS. Again, limited breath sounds. I would add to that. Paradoxical movement of the chest. In other words, when it's supposed to be going up, it goes down, and vice versa. When you're having that, again, major problem. Now, chest wall contusions, okay? Pretty good sign you've got underlying damage up underneath there, okay? You're going to have redness initially, but then it's going to turn into that bluish brown ecchymosis type look. And then the contusions, again, can be discolored, and it can lead to hypoventilation, and strictly because they are not able to expand and contract like they're supposed to, and damage to the underlying lung structure, okay? So if you bruise lung tissue, it's not going to function correctly, all right? Rib fractures, 50% is serious blunt trauma, okay? The ribs do flex, but they fracture at their weakest points, and usually the 4th through 8th ribs are the guys that actually fracture. By the way, if we have 2 or more fractures and 2 or more ribs, we call that a flail segment. And, of course, you want to stabilize a flail segment almost immediately. Again, mortality with rib fractures increase with the number of fractures, the age of the patient, and chronic respiratory or cardiac problems, okay? You got to keep that in mind. Again, so how do you go about this? Feel that rib cage. Go around that rib cage. Palpate that rib cage. If you've got pain, if you feel grating when you're doing this, again, you more than likely got rib fractures, okay? Pain grater in the chest wall contusions, again, it's going to limit the respiratory excursion. Translation, it ain't going to want to expand, okay? So, again, may cause hypoxia, hypoventilation. Actually, the hypoventilation is because it hurts so much they don't want to breathe. Or they will try to take smaller breaths, and that's probably not as good as taking, again. But again, you got to remember, if you got jagged rib ends, by the way, if they take a deep breath, you have the chance of lacerating the lung up underneath there, or any other structure, by the way, that might be under there. Sternal fracture or dislocation usually takes a lot of force to do that, and the mortality due to that is pretty bad because it usually damages the structures underneath. More importantly, your cardiac, pulmonary contusion, cardiac contusion, pericardial tamponade, actual cardiac rupture, okay? So yeah, we can actually blow the heart out by doing these things, okay? A dislocation is kind of uncommon, but the biggest one that will do it is, again, that steering wheel, or if you've done proper CPR, you can actually dislocate the sternum, okay? Flail segments, so 2 or more ribs, or excuse me, it's supposed to be 2 or more ribs in 2 or more places. But again, they define it as 2 or more ribs, and 2, again, in this picture kind of puts that into perspective. Again, even if you got just 2 of them, it will cause, that's the flail segment, it'll cause the same problems, okay? Remember to stabilize the flail chest, and the best way to stabilize the flail chest, bag valve mask, all right? Positive pressure ventilation, okay? The reason is it splints it from the inside. Now, do you put something on the outside of it? Yeah, it's probably a good idea to tape a bulky dressing on that, or something with a little bit of weight to cause it to not extend outward. But you don't want to put so much weight on there that it causes, again, labored breathing with that. So you have to kind of take that with a delicate hand. But the number one way is, again, positive pressure ventilation. All right. So signs and symptoms of a pneumo, chest pain, trauma to the chest. Then we got the hyperinflation of the chest. In other words, and by the way, when I tap on the chest, it'll sound like a drum that's like really tight. And then diminished breath sounds on that affected side. If I had to pick 2, I would probably say this guy right here and this guy right here, the one at the bottom. Most definitely, okay? Now, a simple pneumothorax is just a release of the air into the chest wall cavity. Matter of fact, most of the time, given a little bit of time, these usually reinflate on their own. Now, if we have an open pneumothorax, this is where there is a hole there. What happens is the air sucks in instead of coming in through the trachea, and then when you go to exhale, it comes out. Now, it's okay. We want the stuff to come out, which is why we use the three-sided dressing on that. So what we will do is put an occlusive dressing on top of the wound, of the hole, and let one of the corners up or three sides of it and allow the air to escape. But when they go to suck in, it's going to hold the dressing in place so that it doesn't suck in through that hole. Okay. Now again, you're going to have frothy blood at the wound site usually. And again, the things that cause an open pneumothorax, usually it's a knife wound or a high velocity gun. And then the air replaces the lung tissue and causes the lung to collapse. Okay. The other name, by the way, for an open pneumothorax is sucking chest wound again. And you can get bleeding from around the site. Again, now the problem is when they turn into these little buggers. So what happens is that we build up pressure on the one side, and then again, this is when we start. They have the diminished and then absent breath sounds. You're going to have the hypertympany. Again, that's where you tap on the chest. Long and the short is now the pressure is building up here, and the problem is this starts to displace. This starts to displace the heart. It starts a mediastinal shift. A late sign, by the way, is the jugular veins distending and the trachea deviating to the other side. Those are all, by the way, super late signs. If you have missed the signs, if you're seeing those signs, grab a needle. You need to be sticking it. Okay, you need to be sticking the chest. All right. So again, if you do not relieve the pressure, they will die on you. Okay. So if there's one of the things that Dr. Lautenberg used to always preach, he's the chief of surgery up at Shands for the trauma, is especially if they're in an arrest and they've got chest trauma, stick a needle in their chest. Okay, stick a needle, the one side that you think's damaged and probably the other side. 10% of the time you might give them a pneumo. More than likely you're not. But if they've got a tension pneumo, you're going to save their life. Okay? Again, so tension pneumothorax, air. Regular pneumothorax, air. Open sucking chest wound, open pneumothorax, air. Now we're dealing with the blood of it. Okay? If you've got the blood part of it, again, now this stuff we actually kind of don't want to get rid of immediately. Okay? Now, if it starts to pressurize, then we have to drain the blood off, and that turns into a whole other nightmare. But again, it's accumulation of blood in the pleural space. Now, remember, we can lose 3 liters of blood into that thoracic space. So it's usually associated with rib fractures and accompanying pneumothorax. We usually call that with a hemopneumothorax. So again, and this is an example where the blood fills up. Which is why, guys, we stick up here, just up underneath the second rib, on top of the third rib, is because usually up here we're going to hit air. Down, if we go into the fifth or sixth intercostal space, we're actually hitting, if there's a blood down there, we're actually going to hit the blood. And it will actually start to drain the blood off. And again, that's a very bad thing, because usually that blood ends up tamponading and stopping the bleeding within the thoracic cavity, and then we go and drain it off. Congratulations, you just killed them. Not only the fact that you're draining it off, but now there's more blood loss happening because of it. So again, that's why we stick up here. That's why we stick underneath the top of the third rib. We want to drain air. We don't want to drain blood. Okay? Now, if it gets to the point where the pressure is too much, I got to be honest with you, chances of survival very, very, very slim. Okay? Very, very slim. By the way, usually your pneumothoraxes aren't too shocky per se. Your hemothoraxes are going to have massive signs of shock. Okay, they're going to have low blood pressure. They're going to have a dull percussion to the chest. Okay, there's fluid in there. You're going to hear, instead of point, you're going to hear thump, thump, thump. Okay, and usually down lower in the chest area. A pulmonary contusion. These are the guys that you give them plenty of oxygen and they don't get better. Okay. And they have increasing crackles, diminished breath sounds. They'll be spitting up blood, and again, signs and symptoms of shock. And you're going, wow. And again, but what's happened is you've bruised the lung tissue, okay? It's not going to work, okay? And a lot of things can cause this: deceleration injuries, explosions. All those things can cause it. Now, the problem is that disruptive areas kind of flare out, okay, and it causes microhemorrhages and it causes additional edema to go in there. And it's not usually not associated with low-speed chest-penetrating trauma. It's usually your high-speed or your blast injuries or a sudden, when you're hitting the steering wheel is another reason that you would probably get it. Blunt cardiac injury, again, it's basically bruising or damaging the chest wall with blunt force trauma. And by the way, if it hurts it that good, you're probably going to have a high mortality rate, especially with blunt anterior trauma. That's the reason I call the steering wheel the battering ram. It's exactly what it is. Now, contusions that usually affect the right atrium and the right ventricle, by the way. And it disrupts the muscles. And actually, if you get blunt cardiac trauma, dysrhythmia is actually a very common complication of that, okay? So your old people that hit the steering wheel, put them on the monitor, okay? And to be blunt, I might have a good idea of where my pads are, okay? Trust me, I've had way too many old people actually go into cardiac arrest, 20, 30 minutes later, because finally the damage started to affect the cardiac electrical cycle, okay? But commutio cordis, we're going to talk about this especially when we get to kids. It's a rare event. It's when you punch the sternum just in the right spot. It actually sends a little bit of electricity through, which actually puts the patient into VFib. The one-finger death punch. Yet technically, this is kind of it, okay? We see it with kids like when they take a line drive with a baseball, when they're the pitcher and they take a line drive to the chest, and then they fall over, collapse. That's the commutio cordis in effect, okay? Treat it just like VFib, by the way, gang. Because that's what it is, probably. All right, so pericardial tamponade. All right, it's a progressive. You start out with a weak, thready pulse, decreasing blood pressure, and the pulse pressure starts to narrow, okay? And the reason is because the heart's contracting, it's contracting, but then it starts filling up with blood. So it can't physically expand anymore. And it will go tachycardic, by the way, okay? They will have a lot of shortness of breath, a lot of, they may even have cyanosis with this. The jugular veins get backed up because, again, the heart can't expand, it can't stretch, so it starts backing up fluid everywhere, okay? Again, restriction of the cardiac filling, again, released by related to penetrating injury. Most of the time this is caused due to a knife wound that doesn't go all the way into the myocardium and the pericardium seals. Oops. Okay, so again, the blood starts to fill up in this area, starts to make it where this can't stretch, can't contract. The way that we treat this is, of course, high flow diesel, and getting them to anybody, and I repeat this, anybody that's allowed to stick in the pericardial, do a pericardial centesis, okay? Again, back in the day, we trained on that, no longer in the paramedic curriculum. But you need to get them either to a critical care medic or to a doc, whichever one can stick a 3-inch spinal needle into that area and drain the fluid off, okay? Very important. By the way, Beck's triad and Kussmaul signs are going to be breathing rapid and quick, and the Beck's triad, of course, is the distended neck veins, the narrowing pulse pressure, and the tachycardia, okay? Not to be confused with the other one that we talked about during head trauma, which is Cushing's triad. Cushing's, again, is all about, high blood pressure, low heart rate. Beck's triad, pretty much the exact opposite. Pulsus paradoxus and alternus and electrical alternans. This is the things that can happen with a cardiac tamponade, and they're good signs that you probably have one. Myocardial aneurysm or rupture. Again, you can actually have the heart muscle blow out. And yes, it can develop about 2 weeks after an injury because of weakening myocardial tissue or there's scar tissue on the heart, and it simply blows out. It's actually, and again, I can tell you right now, there's not much we can do for that, guys. An aortic dissection or rupture, if it's a small tear, get them to a surgeon that can repair it. If you don't get them to a surgeon in time, they will die right in front of you, okay? So again, it usually happens on a fixation point. Remember the ligamentum arteriosum? That's actually where the foramen or valve, not the ductus arterius, used to come in, and those are weak spots for it. And so what can happen is they'll actually start the leak at the weak spots, and then it'll turn into a full, usually blown. But this is sometimes accelerated due to some sort of high-speed automobile crash or blunder penetrating trauma. Again, it requires a surgical intervention. Again, the dissections are usually slower. The rupture, unless they're on the table, gang, you're probably not going to get these poor pokes back. All right. Pulmonary arteries and vena cava, remember, these can get damaged, and usually penetrating trauma will cause that. You get a lot of blood in the area. Again, you get a lot of blood. Remember, the thorax can hold 3 liters of blood. And matter of fact, if it expands a little bit more, it can actually hold probably a little bit more than that. Again, a traumatic esophageal rupture, usually mortality if not diagnosed and treated properly. Okay, they'll complain of a lot of burning sensation with this because, again, the acids are starting to come up through this esophagus. So deep penetrating trauma to the central chest can actually cause this. I've had a few that actually kind of came through the back and just got lucky and they got it. Tracheobronchial injury, yeah, these guys usually, half of them die within the first hour, okay? And again, they've got to go in and surgically repair these, and they end up with usually a tension pneumothorax. And here's a news flash: the more you bag these folks, unfortunately, the more subcutaneous tissue. I mean, they're literally just going to blow up on you, and it's a horrible sight to see, by the way. And there's really no ventilation that's happening because of that. One of the things, by the way, with the traumatic asphyxia is you got severe compression of the chest, and then you got a reverse blood flow, and they start breaking out into their eyes kind of bug out. They get a really flushed face, usually like from the clavicle line up, they start turning purple, really in a horrific way to be seen. But these are good signs that you've got the subconjunctival hemorrhage. Is a good sign that you probably got some traumatic asphyxia going on. It usually damages cerebral circulation, which also then throws little blood clots, causes strokes. Again, the acidity continues. You get hypotension, hypovolemia, shock. It's a syndrome of events that happens with the traumatic asphyxia. And again, if you do really, you could actually cause traumatic asphyxias for a lot of chest compressions and going too deep, pushing too hard, okay? The victim's face, again, will start to swell. The eyes will bulge. It's just a gross thing. All right, so I went a little bit long on this one, but there's a lot of things in the chest, and there's a lot of things we got to know about for the test. You can better bet that most everyone that I just said is going to be on the test in some way, shape, form, or fashion. So you got to know these. So read up on those. All right, guys, let's talk to you about the assessment and treatment of this on the next one.